Good. Now a little bit more with your leg. Oh yes, it's coming here. A little bit more with your leg, yeah. And she would sort of just direct, put it back with your shoulder. That's it. Now push down with your leg. Push down with your leg. And she did all this without any sort of stress. And there were little clicks and cracks she used to go because she'd got the patient to take it to the barrier. That's why women are born smart, you see. One of the women at this course I told you about, where we had all these emancipated women, it was a really good course. Have you heard this joke? Have you heard this joke? Okay? I said, I don't want to hear any more jokes about women. And she said, there's this guy, and he finds Aladdin's lamp, okay? And he rubs this lamp, and the genie comes out, and he says, oh master, what can I do for you? Well, it was a man, and he kind of wasn't too smart. So he said, I just want to be made smarter. And then perhaps I'll think of something else to tell you when I'm smarter. So about a month later, he rubs the lamp again, and the genie comes out, and again he says, you know, all I want to do is to be just smarter. And this goes on for about 6 months. He's rubbing this, and he can only think of one thing to be, that's just smarter. And the last time he comes out and he rubs this lamp, and the genie comes out, and he said, I just want to be smarter. I've got to be smarter. And the genie looked at him and said, look, if I make you any smarter, you're going to start having periods. However, there was one guy in the group that kind of surreptitiously came up to him and said, have you heard this joke about women? Quietly. I mean, these other jokes were being talked in the group, and all the guys were kind of looking like this very sheepishly, and there were only about, I suppose, about a quarter of the people in the group, or even less, were men, so we were very low profile. So this guy came up to me and said, have you heard this joke about women? So I said, no, but I'd be very glad to. And we're in the Garden of Eden here, and there's Adam, and he's by himself at this time. And God comes down, he says, Adam, how are things going on? Adam says to him, geez, he said, it's pretty good here. He said, but I'm lonely. He said, is there anything that you could do about this? He said, I'm just sick and tired of being by myself. And God said, oh, I don't know about that. He said, it's going to cost you an arm and a leg to be, you know, for anything to happen. And Adam says, oh, geez, I better think about this. An arm and a leg? What would I get for a rib? I told the group that, actually. Okay. So, can we just look at this last picture here, which is this one. And this is from that diagram that you've got of Kirkcaldy-Willis's articles within your notes. And this is part of what I'll show you also with the diagrams of Cassidy. That we look at coming down here, this sort of classic picture. And I don't know that this is perhaps for Washington, Bill, this sort of diagram. You know, how can we kind of get by regulations which have been stupidly applied generally by ourselves? This is what horrifies me. You can't believe what goes on, our lack of political acumen on most of this stuff. But if we look at this diagram here, which is one of the ones that was developed by de Sèze and also by one of the Swiss chiropractors that writes very, very much, whose name's just gone from my mind for the moment. But we've got this sort of neutral point here. We come out to these 2 points, and these represent the active range of motion. And then we come here, which is the little bit of passive range that we can get beyond the active range. So to this point would still be in what we would call the physiological range of motion. Now then, I don't think that this space here, which they call the paraphysiological space, should be represented as big as that. I'm not even sure that that should be represented as big as that. If we sort of had a diagram like this, I think basically speaking, we're probably coming back that, you know, perhaps this is the active range of motion here, and then we've got perhaps the passive range of motion here, and that paraphysiological, even on this down it's a bit much, that paraphysiological is just a little tiny movement there. Because if we come too far into this, then we're outside the anatomical integrity of this. So when we are mobilizing, of course, we're coming down through the active range into this passive range, and we're doing our various things to try and get this passive range to the normal end of the physiological range of motion. And then what we are doing at some point is going beyond that physiological range of movement, and what happens presumably is that we've got the sort of collagen like this with that slight crimp, and we take it to a slightly stretched out position here. And the consequences of that is that we restore motion or we restore position. Now the question is, where does that physiological barrier exist when we've got pathology? Are we ever going beyond the physiological limit, or are we trying to get, in pathological cases, to the normally accepted physiological barrier? That's the sort of question I think we've got to ask, because we don't believe in exceeding the physiological barrier in a normal joint. You know, I don't know whether we can kind of work this around and speak to a lawyer and, you know, sort of say, this is how we're doing this.
Their crux is the high velocity.
Is the thrust. Yeah. So we perhaps, you know, we're talking about an impulse, mobilization with impulse. We've got to sort of push the political aspects that that all over the world, this is an accepted standard, that the International Federation accepts this in every country. In the United States, it's in most states, but not, you know, this. Why are we being restricted in this state? I think we've really got to sort of talk around all this. And what is the real consequences? Who's being protected by this? Or is it a turf battle? And that's what it is, isn't it? When you come to look at this, it's nothing to do with patients being protected. That's a lot of rubbish. It's to do with protecting political interests, special interest groups.
They've done a better job marketing themselves and sending out the warning signals to the public, saying, well, you know, only chiropractors can do this, and therefore, you know, the physical therapists generally are not trained. Where all chiropractors are trained to do manipulation.
I think this is right. I think we say this is absolutely right. But some therapists who are manual therapists are trained in this, because we don't believe that the vast majority out there should be trained in this, because we cover the whole spectrum of medicine, from neurology to respiratory to whatever, and they don't need all this. But the groups that do need it, we do it only as a postgraduate study. We don't do it as undergraduates, because we believe that you should build up a whole skill level before you learn this. And you should learn it on peripheral joints before you go into spinal joints. I think that's the political kind of pressure we've got to start putting on here. But this is a thing, you know, it's all semantics, isn't it? And what we've got to do is say, okay, this exists, how can we kind of get round this? And this is the kind of argument which might be a bit specious, it might not even be right. But I think we've got to start looking that way to say that we don't believe that this physiological space is engaged until we get to the end of normal range of movement in a joint, when manipulation is inappropriate. When we're at some point in this pathological situation, you're not exceeding the physiological range and the anatomical boundaries, we're just trying to get to the physiological range. And there are a number of ways of doing it, of mobilization, and we do grade 5 mobilizations, or mobilizations with impulse, or we call it something else.
Mobilization with incidental popping.
Yeah, well, the popping is incidental to us, you know. So this is the thing that we've got to all talk about, and in these groups, and perhaps when we have this, you know, this seminar in Seattle or whatever, perhaps some session should be spent on looking at this kind of thing for us.
Well, they're real hung up on the pop.
And we're not. We just say that occasionally it occurs, which signifies that we've gained range within that joint. But we do believe that little impulses are important. And Barb was telling me about some of the work of, and I never got that book from you. I don't know whether we could still, yeah, okay. Mrs. Brand, who doesn't believe so much in sort of creep and things in the body in vivo. And, you know, I think that the sort of little impulse techniques that we do might in actual fact, as we've all observed, they are less traumatic to us very often than repetitive mobilization done at the end of the range. I know that I would far rather have a little manipulation done on my back than be taken to the end of the range and somebody working there for 5 minutes. That kills me. For somebody to get up and just do that, a lot better. And I think only people that know all about muscle techniques and all this should be doing this, because, you know. So I think we've got to work on this a little bit, but not let anything give up. And I reckon that's what the American Physical Therapy Association should be pushing in their journal. Don't give up any single thing for any advantage, because it's not going to be an advantage. You've got to keep what we have. Stan Paris was absolutely right, and I thought he was wrong, to call manipulation the whole spectrum of passive movement, the skilled handling of soft tissues. That's what it says in the Dorland Medical Dictionary. And we tended to make it very specific. But I think in keeping it wide like that, this was part of physical therapy. We believe that not all physical therapists do it, like all doctors don't do neurosurgery. We believe that the specialists should do it. And this is how we train our specialists. So that's the sort of route I think we should take here on this particular sort of topic. Any questions on this? So we've got this paraphysiological space. When we put the patient into the side posture position, we're getting ready to explore this. Then we would gradually sort of increase our pressure to try and get into the passive movement space. And we do it by this pulling the shoulder round, and we'll talk about this in a minute, so that we've got one lever going the other way, one lever coming in the opposite direction, so we focus our forces at the individual joint. And that now is at its physiological, or at the point of the block. We're going to talk about this physiological space. We better start changing the way we describe it, okay? So now we can go into that barrier. That barrier is preventing us getting to the physiological limitation of motion, and that's when we do our little impulse, or that's when we explore, because we've looked at the pain range spasm relationship and we've tried to go through the spasm until we feel that we've got to the collagen or the block feel, the sudden cessation of movement, which is not muscle spasm. Now we know that there's a little bit of muscle spasm associated with this spinal dysfunction, but it's not that hard spasm that's holding the joint. It's that you can feel there's increased activity over that joint in the muscle. And then we do the little release and it's gone. So these are the things I think that are considerations with the lumbar spine manipulation. Now, I've talked a little longer there than I had anticipated, okay? But it's important stuff. Let's have a coffee now. 15 minutes, we'll start again. Straight into the lumbar, or into testing.
Chris, my point was that I bring them to you.
Do you know what's nice about this course at this level? Is the amount of talent that you realize is within a group. You know, and you perhaps are quite, as an individual, are quite good at one bit. And you can talk to a colleague who's really very good on stuff that you'd be totally lost at yourself. And that's really excellent to think that this is the volume of kind of coverage that we do, and you kind of look to yourself and think, I should be sort of, at least have some idea of how to do that and to do this. For the odd patient that I've had, that I really didn't do the best that I could have done that's out there. I mean, we can't all be experts at every single thing. But it's very nice within a group at this level to sort of talk to people with different skill levels at different things that are far higher than yours. And that's really excellent, just excellent. So let's just talk about this. Let's go back to something I know a little bit about here. Thanks, sir. Thank you. See, Anne is an expert at cleaning boards. She must have been a monitor person. Okay. If we just think to ourselves about the profile of the patient, all right? What I said to you the other day was this little ideal profile of the patient would be, and these are not the usual ones you find, the one that's just done it, never had a problem before, relatively young, pain on the side opposite to which they stretch, you know. Probably most of these clear up themselves. They put a bit of heat on it, stretch themselves a bit, and they clear up. These would be very nice to have, because probably one little release, and that would make your reputation. But the ideal one would be, as I described yesterday. And we add on to this those things of Klenians here, which is the straight leg raising. How do we look at this? And what is the volume of information out there? Certainly people like Stoddard, who did a lot of manipulating, suggested that you should never manipulate anybody with a straight leg raising that is less than 35 degrees. Once we get up past 45 degrees, straight leg raising becomes an articular sign as well, doesn't it? So it might not be so significant. But below 35, it probably represents a discal bulge on the nerve. And on the whole, although Cassidy's kind of put a little bit of doubt on this, we don't manipulate those acute disc problems. We just don't do it. It'd be very foolish. And looking at these other things, the contralateral SLR, that's been found to be very, very significant in terms of disc lesions at L4-5. And on the whole, we don't manipulate discs. We manipulate segments where the disc doesn't look to be the major problem within the segment. With Day-Earl's sciatic stretch test, if I could just use Chris for a second. And I was talking with Ralph at the break time, and perhaps we should discuss. Thank you. I think we've got instability, somewhat instability in this in our lumbar spine there. We'll have to put the pieces together again. Okay, with no, sit please, Chris. With Day-Earl's sciatic stretch test, we sit the patient. Now, we were talking about the slump test. You know, the slump test to me is a kind of a pretty extreme thing, and I think we should be talking about sort of sitting dural tests. And to me, the slump is actually slumping, holding it there, coming out like this. And I don't think we should be doing that early on. I think it's something you look at when you can't find anything else. But earlier manifestations of this are part of what this Day-Earl's sciatic stretch test is. Sometimes when we have patients laid down, and Cliff Fowler always made a point, and I did find several patients where this worked in, he talked about young women at about 18, 19, 20 that had sort of backache, a little bit of buttock pain, but when you laid them down you could never find anything. But when you sat them down and gave them chance to sort of perhaps get creep and compression, that it produced a straight leg raising problem when we did it in this position. And so with Day-Earl's sciatic nerve stretch, this would be to let the patient sit, to take the leg out into the position that hurts, to ease off a bit so it doesn't hurt, just as soon as it stops hurting to ease off, and then to come around the back of the sciatic nerve, round the lateral aspect of the hamstring, and just pull on it and see if you can create not local pain, but the sciatic pain that they have. So this is like a mixture of sitting and the bowstring test. And it's a little bit like the work that's been done by Elvey and then picked up and really expanded by people such as Butler, where we could sort of come up, take the strain off, pick up the strain in different areas. It's a manifestation of looking for dural mobility and nerve root mobility. And if we produce irritability in the region of the sciatic reference that they're complaining of, then probably we're dealing with some irritability in the intervertebral foramen. Because a neuritis, a true neuritis of the sciatic nerve is not very common. But an inflammatory neuritis caused by autoimmune reactions or whatever it is that produces this, and all the inflammatory cascade of bradykinin and histamine and potassium ions and prostaglandin E and all that kind of stuff around that causes irritability there. And you remember that experiment? You know, patients are very kind of long-suffering, aren't they? You know, if a surgeon came to you and said, now, what I'd like to do is operate on you, but I'd like to leave a few little nylon loops around a few of your normal nerves, and when you come round, we're going to pull on them and see if it kind of causes anything. Certainly, doctor. Now, in England, you probably say, yes, master. Thank you very much, master. Now you'd say, okay, what's your malpractice insurance like? What was that joke you was telling me yesterday about break if you're rich? What was that one? Yeah, honk if you're rich and I'll put on my brakes. So right, you sort of say to the doctor, what's your malpractice insurance like? Several $million bucks? Certainly. Okay, so this is the Day-Earl's sciatic nerve stretch. And it has this compression element which laying flat doesn't.
How do you spell that?
D-E-Y-E-R-L-E-S. D-E-Y-E-R-L-E-S. Okay, so that's that one. And then we've got the prone knee bend, okay, which would be significant at perhaps slightly higher levels. And then Desjardins triad. Just the triad, like the Valsalva triad. Do you get problems in the sciatic nerve when you cough, when you sneeze, and when you strain at a bowel movement? And that latter one is really important because, of course, they're straining in a flexed position. And so they would put that on as being possibly contraindications. And you can see why, because it's signifying discal problems. Now, for us, thanks, Chris, if we go back to Cyriax now, from our scan, just list out the number of things that you would think about in the scan now that would probably signify don't manipulate this person. That doesn't mean don't apply manual therapy, but we're talking about giving an impulse. And remember, for us, an impulse is not usually a primary procedure. It's one that we do after we've tried the techniques which are in the control of the patient. Then we do the techniques that are in our control, outside the control of the patient. That's why we believe you should be able to be an expert mobilizer before you are a manipulator. Now, what were the Cyriax things? Can you just call out a few? We'll start with Sandy. Talk about pain for a second. What pain would be significant in terms of, wondering about what Cyriax called signs of, what was it? Signs of low predictors of success. These are what we want to talk about, because these are like the contraindicating things.
Extrasegmental pain would be something.
Yeah, we'll put that off at the side here, because we're kind of wondering about this patient even for this sort of like lability and all this sort of stuff. But extrasegmental pain, if we can't sort out a segment, then we shouldn't be using high velocity stuff. If we've got to sort of do manual therapy, it should be muscle stuff and all that kind of thing. So that's a good one, okay? Other things of pain. Yes, all right. Okay. Next one, Suzanne. We'll leave. Sandy's given us two. Just pain at the moment. In terms of predictors of success from Cyriax.
Apply traction, it suddenly relieves their pain, and then it comes back instantly when you take the traction off.
Okay. All right, we're down here. And by traction, you mean done with the machine? Yeah. Okay. Usually there is a big rebound phenomena after this, and you can't get them off the table. Okay. Anything else? We're just talking. We haven't even got to sort of really laying them down or doing anything yet. We're just talking to them about where the pain is. Yeah, and so doing the opposite of that, the obverse of that, would be what? The more localized it is, the more success you're going to have. The less success you're going to have, the more spread it is. So the further into the periphery this goes, and the more severe the pain is, the less likely it is that manipulation as such will work. So the greater the spread, and the further into the dermatome, okay, that wouldn't be a great sign. All right? Okay, we could go into our movement diagram. Let's deal with left-sided pain. Here's our movement diagram. We come in here and we've got pain on the left side. We'd be a lot better with our movement diagram here if when we went to the left and we produced pain on the, we go to the left here and we produce pain on the right side, a stretch-like pain. Very good. Anything else with the pain? How about its development? Sudden onset where? In which part of the body? In the spine, okay. That then spreads if it's going to spread. We don't want the ones that start in the leg and you look back and there are articular signs in the back. What Cyriax would have called primary posterolateral protrusions that went into the leg. We want to have the secondary posterolateral protrusions in his case, but in terms of the pain from that would be pain starting in the back and then spreading a little bit into the buttock and the upper part of the thigh. What we know is that if it spreads right down the leg, we're going to have a lot more trouble with it. Okay, that's a good thing. Any other things? Just list them all that comes into your head. Yes, Bill?
Not affected by mechanical.
Okay. This was what we would get from Mackenzie, that, or also Cyriax, that no movement really affects the pain. And if movement sends pain into the leg, which movement is allowed to send pain into the leg that Cyriax doesn't consider to be an absolute contraindication? Flexion. So if on this thing, if flexion caused pain, let's say on this side, and sends pain into the leg, we wouldn't be particularly concerned as it to be a contraindication. But if some of the other movements, particularly extension, sent pain shooting down the leg, probably manipulation wouldn't be indicated. Okay? What did you say, Bill? Was no movement affects pain and spread into the leg other than flexion. Okay, we're doing it well. Anything else? Yes, Bob? Okay. Actually, we could probably put that down as a deviation anyway. Deviation's bad, and it's especially bad if it's deviated to the side of the pain, because we're thinking about left-sided pain here. So deviation is bad, and that one is especially bad, because we know we're always going to have more trouble with it. Whether it's related to where the nerve root is, that was the kind of common thing, but a lot of work's been done since then and seems to show that you can deviate either way regardless of where the nerve root is. So who knows about that? I don't know. But certainly with Mackenzie's protocol, which seems to be the way to tackle anybody that's got a deviation, you always have more problem when they're deviated towards the side of pain than the other side. I mean, that was observed by Cyriax, and it's been observed and proven time and time again. So if you're going to choose to be deviated, deviate away from the pain. But if you've got your choice, don't be deviated.
Well, I don't know if Cyriax said this, but just from my own observations, people who deviated one way and then somehow shifted the other way was especially not promising.
Yeah.
Responding to treatment.
The other thing, though, perhaps in that sense, is that if we'd got, say, a patient going into flexion here, and they produced an arc of pain like this at some point, that was always considered by Cyriax to be a relatively good sign. You know, they sort of came down, they went over here, and then down, because it means there's some small prolapse or block or something that you can sort of steer around. So it was kind of like significant as being an intra-articular restriction of range.
I was meaning more lateral.
Yeah, you're more lateral, and it's deviating from side to side. Yeah, they are hard, because you kind of wonder a little bit about how that takes place, don't you? Is it some sort of dissecting bulge that goes under the posterior longitudinal ligament? You know, very difficult to sort of do a lot with some of those. Anything else?
I have a question about those articular movement patterns.
Yeah.
The side flexion ones where you drew the arrows, so pain on the same side when they bend to the left.
Oh, you're not familiar with that movement diagram?
No. I think I am. Am I interpreting it correctly?
Yes.
They bend to the left